everybody, welcome back to the Pre-Hospital Paradigm Podcast. We have a special December episode for you. Big super cut of the best of all 24 episodes of our first 2 years. So, hope you enjoy. So, Sports Medicine was episode 9. That was with Dr. Rob Flannery from our Sports Medicine, from our Drzezinski.
That was a fun episode.
No, that was a great episode.
Yep.
And
talking about AED in 3, their new initiative to get AEDs to as quickly as possible to cardiac arrest. Typically, kids, young adults that shouldn't go into cardiac arrest. So I think that was a great innovation of them, and a great episode talking about hypothermia management as well.
Yeah. And I don't think this was that long after Damar Hamlin either, and it was kind of one of the pushes.
It was relevant.
Commotio cordis and all that.
So here's Dr. Flannery talking about the management of the hyperthermic patient.
And boy, was it different, though, when the protocol came out and said, now we're going to stay on scene, and people got really scared. So it took a lot of education.
A ton.
Yeah.
A ton.
It's a huge culture shift, different change.
Yeah, absolutely. And I think, there's not a good thing about any of this, but the thing that makes this work is that you have a half an hour. That first half an hour is so crucial to getting the temperature down.
Outcomes.
If you can get that temperature down within the first half hour, your likelihood of having a good outcome is 100%. There's very few things in medicine that you can say it's 100% of the time. And so you get questions about, what happens if somebody has a heart attack? Well, the Corey Stringer Institute has looked at this. Over 3,000 cases of hyperthermia in an athlete. There was one person that had a heart attack. They were monitoring him. Started to struggle in the tub. They pulled him out, shocked him, got him back, put him back in the tub. Left him in the tub until his temperature was less than.
That's how important it is.
That's how important it is. And so, you can do things like that. Now, you got to know, and you got to have that rectal thermometer and that core temperature so that you know what's going on with the temperature, and then you can transport them once you get down below basically 102. And so, above 102 without, again, getting too far into the weeds, the body can't regulate the temperature. And so we know from all the studies that have been done that an ice bath that is being stirred will lower the body's temperature by about a half a degree a minute, and we saw that at the marathon we were talking, or the triathlon. It was triathlon a couple of years ago, where we had a guy that had a temperature of 108, basically.
That's nuts, yeah.
And we put him in the cold tub. He was in there for 20 minutes. When we pulled him out, it was 98 degrees.
That's awesome.
It was amazing.
Right.
And he walked out of the hospital that day. Like, he went, he checked out, walked out of the emergency room, discharged that day. Really not a whole lot worse for the wear. Where if we take them and send them first, depending on how long it takes to get to the ER,
Correct.
And most ERs don't have the capabilities to be able to take care of an athlete that has a temperature that high.
Yeah. Anybody, not just an athlete.
Not
Right?
just an athlete, but anybody.
We're not singling out the...
No. And I think, kind of getting to your point about what to use, it's not overly expensive. There's just a couple of things that you have to figure out what you're going to do. And number one is having a vessel big enough to hold a human being.
Yep.
And you can go and get, Jordan McNair, I believe the Jordan McNair Foundation, or he was a football player from the University of Maryland. Yeah. Ended up passing away from heat stroke, and his foundation that was created in his memory will get you a cold tub.
Oh.
They're only about $130 if you apply for it. They have a grant to be able to get it, and they will get it out. We've had a couple of schools that have used them. It really doesn't matter what it is, but it has to be in the shade. And the hard part is a lot of times getting the ice. Not every school has an ice maker. Not every school has. So if you know you're going to have those, and it's that planning at the beginning of the year, so that you can go out and either talk to the boosters and say, hey, we've got a practice coming up. We need ice. We don't want it in the tub because we don't want to melt the ice, but we need some place to store it where we can have the tub filled. So we got to be in the shade. We got to have access to water. We got to have access to ice. And those, hopefully you never have to use it. But those are the things that you've got to think about beforehand.
Yeah, cool thing about ice is if you keep it cold, it's not perishable.
Right.
You can keep it for a while.
You can use it forever.
Tell that to the icebergs.
and down a global warming rabbit hole we go. But yeah, and to your point, when we put that training out, there was a fair amount of pushback. I know I certainly answered a bunch of questions. I'm sure you guys did too. Was
depleting resources, time on scene,
and again that stat about that first 30 minutes I think is super important as a take-home point. They really need to stick in their head is what you do is important, right? Mm-hmm. So if that means send somebody across, grab a tarp off the engine, hose from the house, assuming it's not at a sporting event, right? What if you just come across hyperthermia and regular care situation, right? Sending somebody across the Quickie Mart to buy $4 worth of ice, right? And tarping them in the backyard before you go. It's worth the time to do that, right? To save brain cells and save organs. All right, episode 10 was with our very own John Cameron from our UH Institute, and he is our data collection and our EPCR guru, one of a couple in that team. And he joined us again. This was an early one. I think we were still standing. We were still standing, or we just gotten chairs. I can't remember. And yeah, it was
a lot of good documentation talk, though.
We released that. It was recorded early, but released as episode 10. Yep. I don't remember what the scheduling. How the scheduling fell, but so here's John kind of recounting some of his own personal legal.
Yeah,
I'll say not a battle. It was a call he was on, and
how good
that had gone, and how
saved him and helped the patient.
Yep. So here, enjoy the EMS documentation.
Brand new paramedic. I was only on I was new license maybe 6 months, and I was on an accident in which a semi-truck ran over another vehicle, caused extensive injuries to the patient. I took care of the semi-truck driver. He made a statement very clear to me, essentially admitting guilt. Sure. I quoted that in my PCR. I wrote a very good narrative. I was very proud of it. 3 years later, I've moved states. I've changed professions pretty much. A completely different world. And I am brought in to court via subpoena to testify as to what I wrote in that document. I had for 2 hours, just shy of 2 hours, prosecuting attorney, defense attorney, grilled down to every single word I wrote in my narrative. And because I wrote such a good narrative, and I was very proud of the job I did, and I presented the information as factually as possible, I helped that individual who was the victim of that terrible incident to get compensation and get cared for, versus had I not included those statements, then I don't know where that would have ended up. So documentation is important. It wasn't just affecting me, it wasn't defending myself or anything I did, but it helped someone else down the road because I made sure that I documented appropriately in that case. So that's kind of like my little personal reason of why documentation is important to me all these years later that I've been doing this.
It's also important to remember that we talk so often about not putting subjective material in your report. In your case, you did on behalf of the patient who spoke those words. And if you quote unquote, you can use subjective information as long as it's on the patient's end, not ours. We can't use our own subjective information.
I mean, it was this was a particular statement that I put in quotations marks because the patient did tell me that, right to my face. So I was 100% certain I knew exactly what he said, and it was something that needed to be included. So,
and that's patient advocacy, and we talk about advocacy. I stress it so often, but you might not have been a patient advocate for the semi-driver, but the patient who really needed it, that was also under your scope of care with your department. I mean, you worked as an advocate.
Yeah. So the legal stuff, obviously, but again, it is your document. So when you have to be deposed, if anybody has ever had that wonderful, wonderful situation, or ever had to go to court, it could be years later, and there you are. All you have is that piece of paper, or in this case, this electronic document to refer to. So it's super important that you are going to use that tool to then recollect what happened, could be years later, and they could be drilling down on every single word in that. So that's why, for the legal standpoint, it is your document. You write it. You're responsible for it. It is connected to you, and you need to use it as a reference for yourself. Next one would be the operational side. So us, as University Hospitals EMS Institute, we use all this data like we said before. We use it to figure out what meds we're using, what treatments we're using. So the operational side can be really important. Your own agency might use it to determine what resources need to be put where. Even as a hospital system, we might say, hey, look, we need a stroke center in this particular geographic area because we're having these long transport times. So from an operational standpoint, it becomes very, very important to use this documentation also.
I know we often probably don't discuss this, but it's often used to drive our continuing education.
Absolutely.
You know, how many times is something that one of us has caught in a chart has been the impetus for next month's CE or scheduled CE thereafter, or
if you get that last minute, hey, can you add these 3 slides because something came up?
I was gonna bring up this this particular last CE where
pink slips.
Where we snuck pink slips in there, and of course it's transparent to the departments out there. But that was the night that CE went out to the masses to be taught. It was like, oh, we need to get this discussion about pink slip, and that wasn't just an arbitrary thing. People were sitting around and be like, I wonder if we should add something to this. It was no,
but
it was
I think the old mentality of thinking,
data.
Especially when PCRs were on paper, was that you would never look at them, and that's I think exactly it's what you're saying isn't happening, and I know that to be a fact. That
even if it was on paper, if I had that report in front of me, there's going to be information in there that I need to take care of that patient
absolutely
in the emergency department that doesn't get conveyed during the pre-hospital report or even bedside report. There's probably going to be some information in there, and as we dive into this, it's going to be about blood loss, or what did the scene look like, or how much intrusion into the vehicle, like what happened
all
on
the
scene.
information you can't possibly get without us being there.
And that's the thing, is I'm not there. I'm in the emergency department waiting for you guys to bring in whatever patient you're going to bring in. I didn't see what's actually on scene. I need that report to paint me in words what actually is going on so I can better understand what happened, as opposed to just, I've got a patient on a backboard or in a C-collar or in cardiac arrest or AFib with RV or whatever. What was happening on scene that got us to this position?
All right, we turn to episode 11 now, which was our broad pediatric talk with our very own Rainbow Babies and Children EMS medical director, Regina Yaski. It was absolute blast having her on. I mean, there's a lot of joking and whatnot going on behind the scenes, but delivered some very poignant pediatric topics and discussion on care. So,
and if I recall, she had some good talks about the use of albuterol and even and use more if you're starting to heal. I thought those points were outstanding.
No, it was a very good. Very fun episode. And here's Dr. Yaski talking about anaphylaxis in the pediatric.
Yeah.
I
So
don't remember
I had a case where I said he just got his first strawberry, and then there was a photo. So the question I always ask is, what is the difference between an allergic reaction and an anaphylactic reaction? What
singular versus multi-system?
Exactly, sure. Singular versus multi-system. Singular system would be angioedema, meaning swelling of your lips or something. Singular would be just skin involvement. Your skin is an organ, right? So would be hives on your skin. But when you're having multi-organ, 2 or more organs, so let's say you have hives, and then I always teach my residents, and I always ask other things did they throw up?
Correct.
Did they pass out? Because a lot of people think anaphylaxis is when they're having trouble breathing.
Nobody thinks GI.
Nobody thinks GI. Nobody thinks to auscultate the lungs. They're always thinking, they said their throat is closing up, and they're like, anaphylaxis. I need to give it. That's that's the threshold. I'm
we have a similar in the EMS world.
Oh, you do?
Yes. That is a lot of people's
they felt their
threshold.
throat was tightening up. No. So I always ask these things GI. Pulmonary. So when you auscultate them, are they wheezing? So if you're coming into a home and they're they ate something and they broke out in hives immediately or something, or their lips are swollen, and the kid is there talking to you, if that kid is wheezing, and I always ask, does the kid have asthma? If that kid is wheezing, that's anaphylaxis. Right. You have the pulmonary system, you have the skin system, and then, of course, you want to get vitals too, right? They can be hypotensive. Those are the scary ones. So if you are dealing with circulation as well, your circulatory system where they have hives or they have angioedema, and angioedema also covers the upper airway
Sure, of
too.
course.
So if their throat is closing up and, they have hives or something else going on. I talked about the vomiting or they're hypotensive. Those are the ones that are really scary. And so you want to treat them accordingly. And I don't know what the hesitation is with giving epi. I don't they will give Benadryl so easily. Be like, I gave them Benadryl. And sometimes it's definitely it's been diagnosed. It's anaphylaxis. They'll come in. Yes, it's anaphylaxis. And we gave Benadryl. We get the call. I'm like,
So I think that I actually have a partial answer for that. I think that's born out of the adult population, right? And especially the middle and accelerated ages, we use epi with caution, right? And so there's this holdback, and I think it spills over into that patient population unnecessarily, right? Where they're going to be the ones that are going to tolerate it the best, probably,
yes, they
right?
are.
Assuming non-chronic, right? Generally healthy, healthy kiddo, they're going to tolerate it the best, and also have the narrowest threshold for failure if you don't do anything about it.
And they can really come in shock. They really can. And if this is a kid with known anaphylactic shock or they've had anaphylaxis in the past, I'm sure the parents have an EpiPen. That's something, too, you can use, like the EpiPen from the parents.
Just be cautious that it's within date if they've used it, because a lot of those might be very old. They're expensive.
That's true. They are expensive. The pediatric airway, I feel like it's like a cone. It's like a cone. It's like a cone, and the cricoid cartilage is like the most flexible part. It's not really, really strong. So it's
almost like two floppy
to protect
tubes
it's floppy. It's not really strong. So it's definitely a little bit more difficult, to protect the airway of these kids. It's very different.
I want to get back to that oxygen thing and the basic things we can do, but you said something there that probably is worth discussing here is, the conical shape of a kid's airway.
You're going to talk about ET tubes?
We're going to talk about ET tubes because that was a perfect lead-in. Okay. It's a perfect lead-in for that, and we can't skip over that. The trend as of recent is to use cuffed on everybody. Where are we at with that?
I think we're now at cuffed. We're using cuffed on pediatric patients. I remember when it was, we did do from cuffed to uncuffed. Obviously, if you're concerned about severe edema, then you would probably use uncuffed. But in cases, we usually use cuffed. And just make sure there's no leak.
So,
and you're okay.
And if there was, we inflate a little.
We inflate a little bit more.
And I think that's the important part that we need to tease out of here is a little bit, right?
Well, you don't want to cause tracheal trauma.
You don't want to, exactly.
We don't want to hyperinflate.
Cuff to seal.
Usually put about 2 to 3 cc's in. Maybe a little yank, maybe just a little, and that's fine. And then we just tape it in place. You have your capnography, making sure that you get your end tidal in place. It's obviously if there's a leak, so we do auscultate to listen, and if there's a leak, you can kind of hear it. You can hear the swish, and then you know that you definitely have a leak, and then you can go back in and put some more air.
Episode 12 was the 4 of us back in the studio together, and we had again some more leftover medications that were kind of requiring some discussion and some pharmacological related things. So here's us talking about dosing of certain medications and how to get the syringe and volume selection correct.
If you're looking at this syringe here, it's a 10 cc syringe, and the markings that you're going to get are going to be half an ml or 1 ml, and that's it. You're not breaking it down to the fine points of that. You need the tenths of a milliliter, and I'm very pro using the 1 cc syringe to give the accurate dosing. And they're in the bottom of the drug box. If you use our drug box, we have the bag of goodies. Just don't steal it, because pharmacy gets really angry when you take the whole bag of goodies out. They like you to put it back in there. So use whatever you want out of it, but keep it in the bottom of the drug box.
And we're talking specifically about heparin here and cutting that down into much smaller doses. But you should be doing, the provider on their own accord should take some time and mentally work through, hey, if I need to give smaller doses of any medication, what is an appropriate size syringe, right? You went, these only have half milliliter, I think it's third or something on 3 milliliters, something like that. But the point is you need to spend some self-reflection time with what you have available to you as far as volumes. This is, of course, especially important when we're talking about pediatrics, right? If we're drawing up those, small volumes, in many cases. You oftentimes can't do that with a larger syringe because you don't have the proper gradation in there to administer it safely and effectively, right?
A really good sit around the table after hours firehouse drill or EMS drill would be to take a few assortments of syringes, sit there with your protocol book and a cup of water and draw up what's required and just get the mental visual, just doing it down.
Sure.
And if you can draw them up, have everybody verify it and then the next guy do it.
I think that's a great point because a lot of times when we talk about medication errors, and I don't really want to go away from heparin, but this will talk about heparin, is, I take my 60 units per kilo and then I multiply it and then I get, well, this is how many units I need to give. Okay, so let's say they're less than 147 pounds. How do I get there? Right. So I've already broken heparin down to 5,000 units in 1 ml. So if you want to get to 0.8 and they weighed 147 pounds, I'm dividing 4,000 by 5,000. That gives me 0.8. That's my volume I want to give of that medication. My dose is the units. And I think Kayla brings up a huge point where we make medication errors in pediatric patients. It's very easy to say, okay, this child weighs this in pounds. I convert it to kilograms, and then I need to give, I'll use Benadryl just to be easy, 1 milligram per kilogram of Benadryl. So now I multiply that. Okay, well, there's 50 milligrams of Benadryl now in here. How do I get that volume that I want to deliver to the patient? I think that's our biggest challenge in pediatrics. So it's really good to do stuff like that. Syringes are cheap. I mean, what do they cost? 10, 15, maybe 20 cents. Get some water, a cup, and then throw out a couple just common medications that you have to do that and actually drop the volume. It's
make it a 10-minute drill.
Yeah, it's a good practical.
And UH, I mean, you guys did awesome with Certidose. I mean, to cut down on some of our anxiety about pediatric doses, but that's only covering those 3 meds.
Yes.
So the rest of them, we need to be proficient.
Yeah, and you can refer to the pediatric tables too. I'm very pro Certidose. I think a ped arrest or a very bad ped trauma would be one of the most stressful calls.
How often do we get it?
and that's the other issue too. It's low frequency, high risk is one of the challenges, but you can use the pediatric tables as well. I would use the pediatric drug tables. The dosing is already figured out for you. It tells you if this is the dose supplied,
milligrams,
in milligrams, and then it gives you the volume. Let's say Versed, say it's 5 milligrams of Versed and 2 mLs or however it's supplied, 10 and 2. And my child weighs this, you want to give this dose, and that is this many milliliters. And usually you're back to that 1 cc syringe again, because until you get into the higher weighted charts, a lot of your volume's really not going to be over an ml a lot of times for some of the medications.
Absolutely correct. Absolutely.
Each one varies, but you just use the charts. It's so much easier. 3 a.m., that's why they're there. Our partners at UH Pharmacy have helped us update that over the years, always make sure it's accurate, and it's a good tool to avoid any type of mistakes.
Quick shout out to Assistant Chief Bernhard from Highland Heights, who took the time to do all that math for you, right? So
definitely.
The part of our protocol committee, and thanks, thanks Bill for taking the time to do that and making that reference material what it is.
Remember too, on the last episode we talked, the last fifth episode, we talked about not being able to cheat once you've graduated. If I have a pediatric call, and just remember, call ahead, dispatch, hey, get a weight. So I can write that weight down and convert everything. And if this is a seizure call, I've already have that converted. If get it pre-done.
All right, transitioning over, we were in episode 13, and Dr. Spanner, he makes a return appearance, and this was an episode that I really enjoyed filming. His shock episode. He's got just he distilled a lot of shock related topics down, just consumable things that were just perfect for the EMS provider. Mm-hmm. But again, another excellent episode with Dr. Spanner.
I think we jump a lot of things into the shock category, but really, if working through it recently, there's separate categories of those shocks and understanding what all those different shocks are and how to treat them, because you treat them differently. So
and that really provided, I think that episode really provided a good breakdown, and then the treatment to go with not only recognition, but the treatment to go with it.
And I think we point out in the episode, the only common pathway to death is shock, so it's something good to study up on.
Well, here is Dr. Spanner talking about those treatments and epidoses.
they don't die on us in the emergency department.
They die on us.
They die on you guys. And so it's you guys that are going to make the difference whether somebody lives or dies in anaphylaxis. And you don't have time to mix up push-dose epi with anaphylactic shock. Somebody without a radial pulse, I don't care if you take your 1 milligram and 1 cc epinephrine and inject 0.3 to 0.5 IM. It's probably not going to do anything, and you can sit there and rub that while you get a line. But that person needs 100 mics at a time. So without mixing anything, your cardiac epinephrine is 1 milligram and 10 cc's, 1,000 micrograms, divide by 10. There's your 100 mics. Just push a cc at a time. As their pressure comes up, what you gave them intermuscularly is kicking in. Because I got to tell you, when I've seen medics do this in the field, first of all, they got to put up with me because I'm going to give them a hell of a hug. I mean, it takes a lot to give somebody that's not dead IV epinephrine. Right? And they've done it, and then I just order the epinephrine drip. And then I ordered, well, the last one I had this on was, can we use names? Orange Fire Department? I'm
Too late now.
Too late, yeah. Sorry. I don't know. But
No, you cannot.
Orange Fire Department had this lady at a local restaurant who told the wait staff that she has a severe shellfish allergy or peanut allergy. It was one of those two. When they're that severe, I think those folks should just stay home, okay? But she consumed this, whatever it was, and dropped. I mean, that's how true the ones that die like that. And another thing I like to say about anaphylaxis is the faster your reaction, the worse it's going to be. Okay? So Orange Fire is literally across the street. This lady doesn't live if this doesn't work this way. Correct. Okay? They went ahead, they started a line, they gave 0.5 of epi twice. This lady was 62 years old. They gave her 0.5 of epi twice IM. Okay? They gave her Salumedrol, they gave her Benadryl, they started fluids. They did everything they could do, but she didn't have a radial pulse. So when she comes in, you can hear the stridor. The stridor was so bad that I ordered racemic epinephrine, and then I gave her 100 mics of epi at a time. Before we could give her the 100 mics, she arrested.
Coded.
And we then are giving her a milligram of epinephrine because we're resuscitating her. And we resuscitated this woman. You know this story.
No, but you're making a point that I like to use as a teaching point. But finish your thought.
So we resuscitated her for 20 minutes, and I'll never forget Amanda, one of my very favorite nurses. She says to me, she goes, "Doc, what are we doing here?" And I said, I have taught paramedics for decades that anaphylactic patients that arrive alive don't die in the ER. They die on them in the pre-hospital environment, and this person's not going to die. And she looked at me like I was crazy, and suddenly, on our 5th dose of epi, she comes back. And now she's in tachycardia, big tachycardia. We get the 12 lead, and you can see ST elevation. So then I call the cardiologist, who says, "Don, you just gave her 5 milligrams of epinephrine. Could you just let her rest a little?" And I was like, okay, but we got an art line in, we got vasopressin going, we got levofed going, and we got epinephrine going. He goes, "Call me in 10 minutes." And magically, her STEMI's gone.
Right.
Her STEMI's gone.
Little oxygen
and I
deficient
was
there.
like, okay, well, maybe I'm having a STEMI. That was pretty intense.
That was
you know?
intense. Right?
She got discharged from the hospital 4 days later. And then, of course, Danny Ellenberger, he's like, "We got to invite her to our Heart Heroes dinner." And I go, "Danny, I don't want her to eat at our Heart Heroes dinner."
EpiPen's not enough.
We got to start the IV before she comes in.
But there's a lot to take there, okay?
There is a lot, yeah.
They did a good job, but they didn't pull the trigger on the IV epi. That's okay, because they were doing what they could do, and they were right across the street. But I'm telling you, that is the lifesaver. I was on Macedonia, and when we gave it IV, I happened to be teaching that day when one of their street workers, I don't know if that's what they're called, the guys who fix the streets. I don't know. Anyway, sorry.
Well, yeah, one of the guys that work for the city.
Oh, the city, yeah. And he collapsed, unresponsive, no radial pulse, and I said, get an IV, and their captain got the IV magically, and we did the, epi 1 to 10,000, 1
That was a
milligram
beast thing,
intensity.
right?
It was a beast
I think
thing.
I remember that case, yeah.
And we did the same thing with him, multiple pressures when we got him to the ER, but it was that move in the pre-hospital environment, recognizing that this distributive shock was something that they were going to die from. And it's different because all the other shock classes, cardiogenic shock, hypovolemic shock, obstructive shock, have narrow pulse pressures, okay? But in distributive shock, you're going to see the diastolic away from the systolic, and this widening of the pulse pressure is quite unusual in shock.
Right.
And so when you see that normal or wide pulse pressure, you've got to think resistance decrease. You've got to think distributive shock, and you need to press the patient.
I'm with you. In my time as medical director, I've only had one case that I've heard about and or reviewed that it probably would have been required. But then again, kind of talking back, we talked off camera about like blood products on ambulances. Like you have an answer to that question. If you have an airway that you guys can't intubate and otherwise they need help on scene, there's ways to get around that, right? You call for a helicopter, they have those drugs, they have that portion of the protocol if you need that help on the scene. But lots of times you can bag through it. You can put an oral airway in. I mean, you have all these adjuncts that you can do. They don't necessarily need to be intubated. And I talk about this when I'm talking about airway management. You're gonna set up. You're gonna get ready to intubate them, and your failback's going to be, I'm gonna have a bougie available, or I'm gonna put a bougie in my first try to get that tube in, and then I'm gonna have my supraglottic available. And the absolute failback is a crike if I absolutely need to.
Cut to air, right?
Yep. But there's lots of times you can bag through it. You can put an oral airway in, you can just bag them and get them to the hospital.
Absolutely.
And then when you bring them to the hospital, you guys have 2-3 guys or gals on the squad coming into us, and you've got a room full of more resources.
And I think you're hitting on our next point here, which is what is the most important things a medic can do to prepare for field RSI.
Prepare to fail.
Yeah. Prepare to fail, and remember your first attempts, your best attempts.
Yep.
And the one thing I butted heads a little bit with early in my career, and now I totally understand, is a particular person from AirMed will tell you that the least experienced person should be your first to intubate, because how else is that person going to get experience? And if you keep falling back on the people who already have the experience, someday they're not going to be there. So I agree with that too, but just make sure that a lot of your I think preparing for this starts and training. And you've done this 1,000 times in training.
Yep.
You can do it with your eyes closed, but you wouldn't. And your equipment's all ready, and you practice like you preach. You don't just start with the tube. No, you start with the setup, and you start with the protocols, and then you go and move on. And understanding that oxygen's a huge part of this, and you're electing to take somebody's airway, so be prepared to do it.
Yep.
And oxygenating prior is huge.
Previously, you had made the comment, which I think holds true, and I think it's we're going to take this airway on our time. Right?
Yeah.
This is not a hurry-up procedure. This is not something that's, if you're rushing it, it probably it should not be. It should not be done. Which rapid is in the
Rapid's in the name, but the rapid is in there.
It's
for
my induction.
How quickly I'm going to induce the patient and paralyze
sequence
the patient.
the sequence of the agents. Yep. Not hurry up and jam a tube.
This.
Yeah.
No, yeah.
Right. And the nomenclature probably leads to some misunderstanding
And
of that.
there's suggestions out there to rename it medication-assisted airway management,
Which I think is better anyways. It's just you get the hastiness out of it, because, I mean, you want to be hasty, don't get me wrong, but to get there shouldn't be hasty. To get there should be a solid checklist, which we have and you must follow, of getting all your equipment together, performing your Malman Patty. And again, like I think we said before, if this is the first time you're hearing that word, you're not RSI ready.
Right.
You're doing your lemon numerics, looking at your 332s, looking at your Malman Patty score, looking at your equipment, It's a lot to do, and that's not going to happen like this.
How long does a experienced provider take to do all that? Seconds?
Not long.
Yeah. I mean, your checklist is one thing, right? But sizing up your patient and seeing what size tube am I going to use, what size blade am I going to use, what type of blade am I going to use.
That should be pretty quick.
Instantaneously, I can tell you exactly what I want.
Yes.
I actually just recently had my last patient I had came in, respiratory distress, put her on BiPAP. She failed BiPAP. She got worse after an hour on it, and we elected to intubate her. And I had a medic who works in the institute, but she went through paramedic school during COVID, and she has 0 live intubations. I got her first. It's my 1,000th, 2,000th intubation. It's going to be her first. Very organized, very all set up. I mean, this is a patient who'd been in my care for over an hour. We had her on BiPAP. Failed it, but we weren't rushing to her side to we're going to do this. We called respiratory. Everyone was in the room. We did our timeout. We had everything set up. We had all of our equipment. I taught her the way that I like to do intubations, and I do all of my intubations with the head up. And we went in there. She did it. She got it first time. She's like, "Oh, that was really easy." I'm like, "We were set up to do it."
Right.
And I was right. I was right there. Again, I'm the experienced operator in this case. I can supervise her. I know she's doing what she's doing. Oh, you need to go a little bit deeper. There's your view. Okay, now put your tube in. There you go. There's your first one.
Yeah.
Easy peasy.
And I'm sure the patient was oxygenated well before this and had reserves.
100% on BiPAP, and you can do your apneic oxygenation, all that stuff, yeah. And we did exactly what the protocol called for because she was a paramedic. I'm like, what does our protocol say? It says rock and ketamine. I'm like, well, that's what we're going to use then because that's what you're going to use in the field.
And in all honesty, if you're RSI in a patient, it should be one of the easiest intubations you've ever performed. It should be the most relaxed intubation. And if you go in there and you're fighting the patient, just wait. You need to wait a little longer. They're not ready.
Hey, guess who was back for episode 15?
Dr. Jordan Singer.
It was Dr. Singer, yeah. Dr. Singer was back, and we dove into some of the intricacies of cardiac arrest management, more of the stuff off that's not on the protocol page, right? Just why it is we do the things, we do. So here's Dr. Singer talking about why care on scene is important.
An arrest and a post-arrest patient is the quintessential stay and play, do as much as possible. And you kind of hit the nail on the head, which is the care we're doing in the ER is the same ACLS care that you guys are doing in the hospital, or you guys are doing in the field. And we do know there's tons of data to support that care during extrication and during transport is inferior to the care in the house or in the ER. So we don't want to subject our patients to that
inferior
less
care.
than perfect ACLS care when we can do better care on scene and increase the chance of ROSC. And then once you get ROSC, stabilizing them, and once you do all the things you need to do to decrease the risk of rearrest, get them to the hospital to get the care that they need. Well, you're exactly right. It may be easier and you may have all your stuff where you need in the ambulance, but that's going to lead to a delay in some of this very important care that is better and more effective if it happens earlier. And so you're exactly right. If it's a dangerous house that you didn't think was dangerous till you got there, maybe the family's starting to get aggressive because they're stressed out that their loved one is in cardiac arrest, you may need to get out of there before you render the rest of the care. And that's fine. Document that in your PCR, and that's totally okay. But if the scene is safe, we want to do it right where we find the patient. I mean, another example is in a nursing home. There's no reason to extricate from a nursing home. Just treat them right where you find them. And a lot of those patients are the ones who are arresting on us. And then if you have to extricate partially, you don't have to go, once you start extrication, you don't have to automatically go to the rig.
All the way, right?
Maybe they're in a tight spot and you get them out in the hall and now you have space to work, then work them there. Like you can do a partial extrication, finish the resuscitation, and then extricate fully once it's the time to do it.
Why is it so important that we maybe stay in play and not take that time to extricate? If I'm taking time to load the patient and I'm putting them on a cot and I'm getting them to the squad, what am I losing out there that I could have been doing right there?
So there's two specific things. The first is that during extrication, you're not going to be able to effectively bag a patient if they don't have an airway. I mean, despite your best effort, you're not going to have a good seal and be able to consistently do that. You're not watching the monitor. You're not working on access. You're not doing all those things that are important. And then if you don't have a Lucas, you're probably not doing good chest compressions because it's next to impossible to do it without a mechanical device during extrication. Right. And then the other thing is, you're delaying all those treatments. So you're doing ineffective CPR during extrication, and then all the other important stuff, such as advanced airway, IV or IO medications, you're just not able to do because you're carrying someone out, and you can't do them at the same time.
Missed opportunity to defibrillate a shockable rhythm that in the time you extricate is now,
And the earlier we do those things, the more likely you are to get ROSC. And when you do get ROSC, the less likely they are to have irreversible brain injury, right? We're not in the business of ROSC. We're in the business of neuro-intact recovery. We want people not just to survive. We want them to walk out of the hospital and have a meaningful life. That's the goal.
Right.
If you put too much stuff in it and it weighs too much, there's incentive then to not bring the pack in. So if you make it so it's comfortable and only the critical things are there, people will do best practice.
It's going to go in the house more. Yeah. Especially when let's say you get dispatched with that chest pain call, and to your point, well, it's a chest pain call. I'm just going to take the monitor, right? Yeah. And that, we all know that. We all know those tricks, right? I'm going to just take the monitor. I'll do my 12 lead, and then you get they're in cardiac arrest now. Yeah. Oh, now I need that bag.
They're in VFib.
Correct.
First time he turned into a VFib arrest.
It's those little things, and I agree with you 100%. You got to set your tools up to perform. Don't take your whole entire ambulance in the house.
It can even be shorter than that for a DOA. You can just give me the DOA criteria. Say, I have a patient that I think is a DOA. They're in rigor mortis. I don't need anything else.
What else do I need to tell you?
I mean, it's irrelevant at that point. So if you tell me lividity everywhere, decapitated, incinerated, you say what the DOA criteria is, I don't need anything else. It's good enough for me, time of death.
Ours is more of mine's a coroner thing. That's why I know, they have their little things, so I just say them. But yeah, it can be very pointed, I think. But some people, to your point, want to give this long. Yeah. And if you don't sound confident either, that's not really reassuring on your end.
Correct. He's going to want you to work at that.
Yeah. If they're
let me figure this out.
I don't know what to do, but I called you, and it's okay, this isn't good. Like in your world,
I think the consensus is though, because we've talked to, Dr. Hill obviously had the same answer you did. Dr. Spanner was, tell us what you want and then tell me what's going on.
You want to frame what I'm listening for so that I don't get to the end and I was listening for this, but it's that you need. Yeah. One other thing I wanted to kind of discuss, another one of the things I've noticed with some of my crews when I review things is we should never be holding compressions for airway. Clearly it's going to be easier to get an advanced airway when compressions are held, but we already know that compressions are far more important than advanced airway. So if you can take a look and get that airway through compressions, great. Put in the ET tube, perfect. But if you're like, you know what, I can't do this, I want to say hold compressions, bite your tongue, do not say those words, and just put in a supraglottic. Just because you didn't get an ET tube, I wouldn't call that a failed airway. I would say that you made a expert decision based on the person looking that this airway was not going to happen through compressions, and it was better to maintain compressions and throw in a supraglottic. And I'll applaud that every time. Yeah. Heck, if you decide I don't even want to go for an ET tube, I'm just going to throw in the supraglottic in 2 seconds and move on to bigger and better things, then that's often even better. And there's data to say that just going for a supraglottic before an ET tube had been associated with better outcomes. And so just something to consider.
All right, and then we were on to episode 17 with Dr. Greg Stefano and Jeff Patty from Geauga, interventional cardiology. I thought this was a great episode. Talking about STEMI care. Yeah.
Great live show. A lot of interaction. Good questions.
Yeah, the live show on this was fantastic as well.
And even the setup they had beforehand with all the different caths and stuff in it, the stents. I thought that was cool.
Yeah, no, it was an awesome episode. So here's Dr. Stefano talking about EMS and STEMI care.
It is a team effort. There's no doubt about it. We have been extremely successful at Geauga and throughout the system. I feel very strongly because of our work with the EMS. I mean, now it's sort of, cruise control in a way right now. But I mean, when we really started this 10, 15 years ago, I mean, doing the stuff in the field, right? I mean, it was an uphill climb, not because people weren't willing, just because people weren't really doing it, right? I mean, when we're talking about doing early meds in the field, everyone gets a little, hesitant. I mean, now it's routine right?
for us. Yeah. But I want to talk more about those meds later.
Yeah, of course we'll get there. But so really, this is a team. I mean, it starts and it's all up front, and so we have to be able to communicate as a team as well. Yeah. So I mean, that's the biggest piece with all of this.
I think it's cool that you mentioned 10, 15 years ago. It's still in its infancy, and it's progressed so much. I mean, in 10, 15 years from now, when I did this, it's been 20 years ago. We didn't learn how to look at EKGs. In
Yeah,
the
you
field.
beat me to the punch, right?
Yeah, we were looking at 3 leads maybe that were electric and just went,
Yeah.
and then if you were lucky, you could print them. But we looked for asystole.
Yeah.
And then, maybe VTAC and VFib I think we were familiar with, but other than that, I mean, we were not doing 12 leads.
Yeah,
That's
20,
for sure.
25 years ago when I went to medical school, I mean, that was solely the domain of the physician, right? It's just like, oh, no. Maybe a hospital medic was trained as a tech to put one on.
Put one on, not read it.
I mean, we didn't have the tech in the field, right? Not by the tech, I mean technology. Obviously, what cell phones, wireless data has revolutionized that and continues to, right? That's been the big driver of this, what we can get out. We were just talking off air. I mean, we really expect even ultrasound and whatnot in the field here. By the end of my career, that'll, you guys will be looking at that real time with us.
Yep.
We've the data has caught up, but you beat me to the punch. It's like 20, 25 years ago, we weren't even taught this taught 12 leads in paramedic class. Basic electrophysiology, and that was it.
Einthoven was a man.
Was a dude.
But no, I mean, and to your point, I mean, even now, look on the bomb squad, we have records now of what the normal EKG was for any of the members, and we're comparing them.
We trend those. We trend those real time after cases if we need to. Yeah, but I'm so glad that you stated that approach that you have to have, right, for optimal patient outcome, right? It's got to be a patient-centric approach with a team of both pre-hospital and in-hospital, because I can certainly remember a time I still periodically hear it crop up. It's like, why do I need to do the EKG in the field? They're going to do it in the hospital, right?
Yeah.
And that just aggravates me to my core. The good news is that slope has tapered greatly, right? I don't feel that question much anymore, but that's infuriating to me. Simply from we're here for the patient, and we have to be part of the team. We have to be your eyes and ears, right?
Yep.
And to your point, most of the credentialing organizations actually frown upon. If you have a high-quality pre-hospital EKG showing STEMI in the field, if you're stopping in the ER to do an EKG, that's a problem.
Right.
You need to be bypassing the ED and going to the cath lab.
Right.
Because why would you repeat it if it's quality and you already activated? Just go to the lab whenever possible.
Yeah.
But I mean, sort of piggybacking on that before I think we get into, a million ways to go.
Sure.
First and foremost, we have a system policy where it's, you call a STEMI. Like I said, there's no feedback, negative feedback. No one's going to be like, oh my God, that's why
bullshit.
they call it.
This wasn't
ridiculous. We never do that. And if, quite frankly, if anyone is, or if you get that feedback, I would love to hear that.
Yeah, we need to know about it. Right?
Exactly, because that's not, because listen, at the end of the day, if you even think there's something, just send it and activate, and we sort it out, because you never know what's going on in the lab. Giving us that little heads up, especially in the middle of the night, getting teams in. It's much better to call off the dogs, right? And I've had many discussions like, hey guys, I see what you're talking about here. I don't think this is a STEMI. Yeah. We're okay. There should never, ever be like, oh, I shouldn't send this. That is the worst thing to do.
Episode 18 brings Dr. Singer back for the third time. He's getting to be one of the more regulars here. And Dr. Singer had all kinds of knowledge that he brought about psychiatric emergencies and pre-hospital care, and all the intricacies that come with that. So here's Dr. Singer talking about who has capacity and who we can take against their will. I guess first and foremost, let's hop on the capacity thing, right? What gives us, when do we restrain either chemically or physically these psychiatric patients? What where do we start with that?
Yeah, so there's two situations where we are going to be asked to transport patients to the hospital against their will.
Yeah.
And in those situations, we may have to use chemical and physical restraint. And if we ever do use physical restraint, it should always be in association with chemical restraint, because fighting the physical restraint can be quite dangerous for the patient, and we don't want that to happen. But these two situations are when they lack capacity and then when they have pink slip in place. And so if a psych patient or someone with a psych emergency lacks capacity, you do not need a pink slip. But if they have capacity and they also have a psychiatric emergency that puts them at imminent risk to self or others, that is when a pink slip is needed, because you can't force them medically because they have capacity, but we know they need to go. And so you bring up the first thing, which is what is medical decision-making capacity, because this is something we have to do for every refusal and transport, which is there's 4 components, and if a patient meets all 4 of those components, they have capacity, and we need to respect whatever decision they make, whether we agree with it or not.
Right, yeah.
And these are, they need to consistently communicate a choice, so they are verbalizing, I want to do this, and they're pretty consistent with that, not bouncing all over the place. They need to understand the medical issues at hand, so understand what could be going on and what that actually means. They need to understand the consequences and risks and benefits of going to the hospital, not going to the hospital, doing X, Y, and Z, and then they need to be able to reason through it in a linear way. We may not agree with their reasoning, but it at least needs to semi-make sense how they got from point A to point B. And if any of those components cannot be met, they lack capacity, and then we are legally obligated to do what we believe is in their best interest. But if they have capacity, we are not allowed to transport them against their will, because that would be kidnapping in that situation.
And I guess, we've joked about this on some other episodes, but it seems like the subplot of this is, call med control is your friend. And this would be a situation where, I don't know, maybe 10 minutes ago, right? Exactly that happened. And then, we were recording another episode with you, and exactly that case. Can you just talk about that case in broad terms? That just he took that call, just a few minutes ago. So
I had a crew that was at the scene of a patient who they were worried lacked capacity and was refusing to go to the hospital. And so in that situation, if we don't transport them when they lack capacity, that's patient abandonment. So the crew correctly identified that this is very nuanced. This person was kind of on the board of, he wasn't sure if she did or did not have capacity, so he wanted me to talk to her so that I can give my impression. And I completely agreed with him. I thought that this woman lacked capacity, and even though she was refusing to go, we had to do what we were obligated to, which was transport her. And then I gave him recommendations for sedation if need be, but said, hey, if you can kind of convince her to go, it's best to do it without sedation, but we're going to get her to go regardless. And if it escalates to the point of sedation, here is what I recommend. This is the safest option in that situation. And then the reason that it was beneficial that he called me is, one, we now have him thinking she lacks capacity, I think she lacks capacity, and it's on a recorded line so that we can review it later. Or if there's ever question after the fact, we can say, well, this is you talking on the phone, and it's pretty obvious
you put her
after
on
the fact that you couldn't demonstrate capacity. So it's legally protective to call your medical director or med control to kind of discuss it to make sure we do the best for that patient.
Yeah, and I don't know if that was outright stated, but you had the patient put on the phone.
Yes.
And you spoke directly with her.
I spoke directly to her, which is important, and you should request that med control do that, not just, I think they lack capacity, but ask that physician speak with the patient and really make sure that they agree with you.
And the other thing too that I like that you did there, you pre-planned any type of hurdles. If you already planned out if this, if the patient becomes combative and stuff like that. So it's just, I like that, and I like that you did it that way. It just makes it easier. That actually avoids another call.
Correct.
So, and that's maybe a good tip for some of the providers if the physician doesn't do what you just did. If the patient does lack capacity and I want to get them to go and they become violent, this is what I'm thinking. I'm thinking of giving some Versed. Are you okay with that? And sure, up to a max of this. Okay, great. And then now we have that one step forward thinking, which I think is very beneficial in the patient's care. And then that's also going to avoid a repeat call or any type of delayed care.
Yeah, we have the luxury of having so many EMS board certified doctors, let alone EMS minded doctors in the UH system. But there are those. You're absolutely right. There's those ER docs that don't have a full sense of what goes on in the EMS world or what they should plan for, what's going to unravel, it becomes incumbent upon us to prompt them, right? Because again,
we're lucky.
Asking that is not an unreasonable question, right? We're lucky in the fact that most, guys like this are going to say, hey, and then I can see how this is going to fall apart, right? All right, do this. Here's your order set. But it's also not inappropriate to say, all right, Doc, cool, we're going to do that, but how about we pre-plan for the next thing, right?